topic for today is, can exercise match depression? It should be antidepressants for efficacy in the treatment of depression. So we're going to look at the comparison. This had come up from a case discussion talking about the potential role for physical activity in patients with depression. So there are three objectives: to identify the benefits of exercise for mental health, and just overall the benefits of exercise. We'll take a peek at that. To compare antidepressants and exercise for the treatment of depression, but then we're also going to look at some of the limitations related to the literature. The literature on exercise for depression and mental health is relatively robust, but there are a couple things that we really need to keep in mind, which made it a little bit more complicated to look at the actual findings just because of the variability. So where to start? I wasn't sure exactly where to start. So I figured we'd start at the beginning. Is exercise even recommended for the treatment of depression? The answer to that is yes. So in a number of different treatment guidelines, any type of physical activity or exercise is recommended, especially for patients with mild to moderate depression. This came from the World Health Organization. They have some resources on evidence-based recommendations for the treatment of depression. And some of the interventions that they recommend are therapy and counseling, behavioral activation, relaxation training, including mindfulness, and then physical activity, exercise, and antidepressants. Our focus for today will just be on those last two, although you'll see kind of a smattering of a number of the others in some of the systematic reviews that we look at. I'm having a rough Friday, so I figured not everyone is a huge fan of exercise, so we wanted to liven it up with a couple of the slides. So recognizing not everybody's a huge fan of exercise and they do need to be talked into it, I thought it'd be helpful to take a look at the benefits of exercise. There are a number of them. There have been improvements that are seen short-term, acutely right after an individual exercises. There are more intermediate term benefits that are seen, as well as long-term benefits. So starting at the top, there has been some evidence to suggest that physical activity can improve thinking and cognition. Some of this was done in elementary school kids. They looked at individuals who had their gym or recess time eliminated due to a number of different reasons, and found that some of their academic scores actually were lower. And when they instituted pilot programs where the kids were able to be outside to go run and play, the gym was reintroduced, they actually saw improvement in those scores with no other changes to their programming. Additionally, more long-term, regular exercise and physical activity has been associated with a lower incidence of dementia, so preserving some of the cognitive functioning. I know that when I have really busy days, I like to go outside and run. Sometimes that can help keep your head clear. So I think from a short and long-term standpoint, there's benefits that are seen in that area. Exercise has been shown to improve sleep quality as long as the intense exercise isn't done immediately preceding bedtime. It tends to reduce anxiety or stress symptoms where individuals don't feel quite so overwhelmed. It improves cardiovascular functioning, and this is in terms of cardiac health, lowering cholesterol levels as well as lowering blood pressure, could also lower your heart rate. It can lower cancer risk more long-term, not necessarily one of the short-term benefits. We see weight management and interesting findings with that. Obesity is linked with a number of conditions, but so it may actually have a benefit on the subsequent development of some secondary conditions, depression, anxiety related to being overweight or obese. Improvements in bone strength, preventing fractures, and improvements in balance and coordination to prevent falls, especially for older individuals. So relatively robust amount of benefits that we can get from physical activity. On the mood side, it has also definitely been looked at for depression. So we're going to look and see, can physical activity really keep those depressive symptoms from crashing in on patients, just in general? This was a meta-analysis that was done. It included randomized controlled trials of adults with depression. The asterisk is there as a reminder for me. They included depression, minor depression, major depressive disorder that tended to score more as mild or moderate, dysthymia. Some of the patients had treatment-resistant depression, non-seasonal depression, and dysphoria. So depression, yes, but not necessarily all in one particular category or one specific diagnosis. The clinical trials could include a number of different interventions. Exercise was allowed to be aerobic or non-aerobic. The two types of exercise that they eliminated was Tai Chi and yoga. They felt that some of the mindfulness activities related to that were outside of the scope of just physical activity. So they did not include those trials, but any other aerobic or non-aerobic activity like strength-based training, things like that. The control groups in these trials varied pretty significantly. In some cases, there was a placebo. So potentially they were in another type of group. There could be usual care. So an exercise intervention was added on top of the regular care that patients were getting. Other treatment, so any type of counseling or other services, and then wait list. This was used quite a bit. So it was, okay, you're randomized between two groups and everyone is going to get the intervention, but one gets it initially and the other has to wait a period of time so that they can compare the two. They included 23 of the clinical trials and had just over 970 patients. The outcomes that they were looking at explicitly were changes in depression symptom scores, and they had a whole variety: the Hamilton Depression Rating Scale, the Beck Inventory, the Montgomery-Åsberg Depression Rating Scale, so they used a whole bunch of different ones. And a couple of them were overseas, and they may have used their own country-specific depression rating scores, so there was quite a bit of variability there. So what did they find? When they pooled these trials, they found that there was a reduction in depressive symptoms that was in favor of exercise. And it was a moderate to large effect size with the G of 0.68. So their cutoff was about a 0.6 was a moderate, or a 0.5 was moderate effect, and 0.8 was a large effect. So being 0.7, that really was a pretty significant improvement in the depressive symptoms. As you can see, for the trials that are listed here, I took this right out of the article itself. Most of them did demonstrate pretty significant benefit for exercise. So if the entirety of the box and the whiskers, so the line and the box, are completely on the left side of 0, it shows an improvement in favor of exercise. If they touch that 0 line or they're over it, means there really wasn't a difference between the two. So for most of the trials, they did see generally benefit for exercise, although there was quite a bit of variability in there. So that bodes well that exercise can be effective. But we want to know, how does it compare? How does it compare to other treatments? This was a different systematic review that looked at not only pharmacologic interventions for major depressive disorder, but a whole bunch of non-pharmacologic interventions. Cognitive behavioral therapy, they looked at light therapy, they looked at acupuncture, human medicine, different supplements, as well as exercise. So physical exercise, I gave you the little green arrow here, is in the low category. But if you look at what the standard mean difference was in the pre versus post of the depression symptoms, it's more moderate to high levels of improvement. And it tends to be a little bit more in line with cognitive behavioral therapy and some of our antidepressants. One of the reasons it was listed as low, even though there were 11 trials, there was a lot of variability and potential for bias. So that limited how strong they felt that data was. So still looks to be effective. How effective? Let's see if we can take a little bit of a closer look. We're going to do the head-to-head and looking at exercise versus antidepressants. And I thought this picture worked well because the trial we're going to look at actually looks at sertraline. So this was a randomized parallel group trial that lasted 16 weeks. It was adult patients that had depression. They had depression, but they were not currently in treatment. So they could have had the diagnosis, they could have had it for a little while, but they weren't actively receiving counseling or any type of antidepressant medication at the time. They were randomized into 4 different groups. A supervised exercise group, so they had to go to a gym and they were there at a particular time to exercise either with a personal trainer or with a general group. There was a home-based exercise group. This group was linked up with a personal trainer that would call, and they did do a couple home visits to help the individuals set up what their home exercise regimen was going to be. There was a sertraline group and then a placebo group. In both of these groups, there were identical pills that were given to the patients, and they could go, they started at 50 milligrams of sertraline as 1 tablet, and they were able to increase as needed up to 200 milligrams, so up to 4 tablets total for both the sertraline and the placebo group. In terms of the exercise, most of it was aerobic exercise. The regimen that was developed had a 10-minute warm-up, 30 minutes for the supervised group where they were walking or jogging on a treadmill, and then a 5-minute cool down. In the home-based exercise group, it was also a 10-minute warm-up and then 30 minutes where a patient was maintaining their heart rate within a predetermined heartbeat range. So they really wanted them to have a certain target of beats per minute that they were maintaining over that 30 minutes. In some cases, that may have been on a treadmill or walking in a neighborhood. In other cases, it may have been an exercise program, usually an aerobic exercise program or stations that they had set up at home, and then the 5-minute cool down period. So there was a little bit of variability between the two. And then from the home-based group, they self-reported how frequently they were doing that. And there was a pulse tracker, a heart rate tracker that they had that would help corroborate that information. So what did they find? There are 3 different categories. So the blue bars are going to be our supervised exercise group. The red bars are the home exercise group. The green bars are the sertraline group, and the purple bars are the placebo group. So our first set over here are the number of patients that went into remission. Now their baseline depression scores had them about moderately ill. So their average HAM-D score was about an 18. So not as severely depressed. Likely that's why they weren't on any type of current depressive symptoms, but they were able to go from 18 down to less than 7 on the HAM-D. And we see that with just under 50% for all 3 of the treatment groups. So both of the exercise groups as well as the sertraline group. None of those 3 groups were different from each other, but they all were significantly different from placebo. Interestingly, they had 30% of the patients with a placebo response. So 30% of the individuals who got placebo went into remission. Their depression symptoms got better. In terms of changes in their Hamilton depression rating scores, you can see the differences here. So even though there were more patients in the exercise groups and the sertraline group that went into remission, the overall changes in their depression rating scores were about the same across the groups. They did find a couple of patients that had really robust responses, so had pretty significant changes in that, and that may be what resulted in not seeing those outliers may have changed what the average change in rating scales were. Last piece is related to adverse effects. So not a surprise, the sertraline group was most likely to have adverse effects reported. I thought it was interesting that the home exercise group was the next most frequent to have some adverse effects that they were reporting. So it could have been gastrointestinal effects or even muscle soreness there, but generally well tolerated overall. From a discontinuation standpoint, the placebo group, that was the group that discontinued most frequently. And of no surprise, it was because they didn't feel that they had an improvement in symptoms. The supervised exercise group was the next most likely to discontinue, and it may have been related to structural issues in terms of the time that they had to show up, how long they needed to be at the gym facility and things like that. The sertraline group was next, and then the home gym exercise piece was they were least likely to drop out. Although there was some question because it was self-report if they were still exercising. So overall, it appeared that the exercise regimens for patients with mild to moderate depression was about equally effective with the sertraline. And the dose of the sertraline, hold on, because I wrote it down, was about 125 milligrams. So just over 2 tablets for both the placebo and for the sertraline group. So they didn't just stay on the 50, they did increase the dose a bit. So it looks like it could be pretty comparable, at least for that patient population. So instead of doing an either or, could we do a both? What about having it added on board? So this is a randomized open label trial for 16 weeks. It was done just in adult women with depression, and it was a relatively small sample size. But what they did is they had patients who had depressive symptoms that still had moderate depressive symptoms. They either continued them on the treatment that they were on, and the vast majority of them were on antidepressants. Some of them also had additional counseling. And then they randomized them. Part of the group went and added exercise to their treatment regimen. They had to go to the gym. So it was a supervised setting. It was 45 to 50 minutes, 3 times a week. And the exercise program was developed in collaboration with a physical trainer, as well as with a therapist. And the goals of the exercise program were to improve the patient's physical fitness, to distract their attention from their anxiety and stress symptoms, to provide social support, so they all went together at one time, to increase the sense of control and self-esteem. So the patients were able to do a couple different things. So sometimes they played games, sometimes they had stations, but they also could monitor and track their progress. And they had some control over how quickly they decided to progress. The program was designed to enhance a self-achievement and accomplishment and to promote behavioral change. So what they were able to find is that the exercise group had an improvement in depressive symptom scores compared to the group that didn't change anything else. That was just the control treatment as usual group. And you can see they used the Beck Depression Inventory. So at baseline, they were both about the same. So they were really moderately depressed. And at endpoint, at the end of those 4 months, the control group really didn't change. It looks like maybe there was a small increase, whereas the exercise group did have a what they considered response. So a pretty significant decrease, more than 20% decrease in their symptoms. The other things that they found was that there was an increase in self-esteem. The patients in the exercise group reported less anxiety and stress. And they also improved most of their physical fitness parameters. So a number of them had lowered blood pressure. They had improvement in glucose and cholesterol levels. Their overall VO2 max capacity had increased. So they were showing other medical improvements as well. So all good news. Does this mean that exercise is going to work for everybody and that it's completely worth the effort? Well, maybe. There are a lot of drawbacks in issues, considerations with the literature that's available. The number of control groups, how do you control for this? Is it treatment as usual? Is it a waiting list? It's somewhat unethical to not treat a patient, especially if they have more moderate to severe depression. So how are we able to standardize that? In the 2 trials that I just showed you, it was either patients that had not been on treatment before, or patients who had pretty much been stable on what they were on and still had existing symptoms that we then added something on board too. So we really need to think through how that's done. If all of the interventions are started at first, it would be really difficult to determine, is it the therapy that's helpful? Is it medication that's helpful? Is it an exercise regimen that's helpful? Other limitations when we're looking at some of the exercise literature is the standardization. Are they doing aerobic exercise, anaerobic exercise? How often is this happening? For what duration of time? What's the frequency during the week? And is it supervised versus unsupervised? How are we able to tell that they're following through on this? With the adjunctive treatment, I forgot to mention the socialization tended to be one of the first pieces that improved and seemed to be an indicator to demonstrate the greatest amount of improvement. So those patients that really were having a positive experience with the socialization with the people they were exercising with seemed to get the most benefit in their overall depressive symptoms. So something to keep in mind, the authors had commented that initially they were just all complaining about it, but they just let them do it because it was kind of a way to rapport build within that group. The diagnostic clarity. So there's actually evidence looking at exercise as a prevention for the development of depression. So sometimes the populations that they include don't necessarily have a diagnosis of depression. They may just have some depressive symptoms, or they may have differing dysphoria. They may have, some of them had refractory depression. So really making sure that we're clear on what the diagnosis is so we can extrapolate who this would be most beneficial to. Knowing if it's adjunctive versus monotherapy, is the exercise the only intervention, we adding it to something different. A lot of the trials, so there are over 3,000 publications on exercise for mental health conditions. A number of them are done in different places around the world. So taking into account cultural norms in terms of feasibility for the amount of physical activity that's being asked. So if someone's being asked to do weightlifting and they don't have access to a gym, then that's not going to be realistic, versus someone who already has a really physically challenging daily life where they're doing a lot of physical activity anyways. The potential benefit they'll get from upping that may be very different than someone who has a much more sedentary, normal daily life. Other comorbidities, they've looked at this in geriatric patients, in patients with mild cognitive impairment. They've looked at this in patients with cardiovascular disease, as well as some patients with cancer. And in each of those, there are different considerations. And the amount of benefit that we see does seem to change based on what some of those comorbidities are. So those findings that maybe it's a moderate to large effect size may not hold true with absolutely everybody. Exercise isn't for everyone. So the recruitment strategies, in a lot of cases, it was volunteers. So they would put posters or some type of advertisement up on social media, on billboards, it just being promoted by posters in different healthcare settings, at bus stops and things, subway stations, things like that. So only the more motivated individuals tended to enroll in some of these trials. So that may have helped boost, even though not everybody finished, but that may have helped boost some of the adherence to treatment, as well as the response that had happened. If that was something they wanted to do anyways, and they were given some structure, that may inflate the efficacy that we see. And then the trial duration, most of these were relatively short term. So looking out about 4 months. So we do see improvement. It would be helpful to see if the physical activity continues to improve. And there's some suggestions that long-term we'll continue to see additional benefits. So even in some of the trials where maybe the effect size was smaller, we might see that increase if the trial duration and follow-up can be a little bit longer. So just some things to keep in mind. So in summary, exercise is recognized as a beneficial intervention. It's included in a bunch of the treatment guidelines for depression. Depressive symptoms have been shown to improve for patients with mild to moderate depression in an equivalent amount to at least the SSRIs, at least with what we saw with sertraline, and actually with the tricyclic antidepressants in that other meta-analysis. And it doesn't have to be a one or the other. We could potentially combine the benefit of both interventions to help the care of patients with depression. They don't have to start big at all, but just doing absolutely anything and starting to move around. They suggested even starting with 5 to 10 minutes of activity once or twice a week, and building up from there can really help, especially with patients who may have more moderate depression, and that motivation to do something extra could be seem really daunting. With that, I'm going to